Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget that you can download the PDF of today's ECG down in the description below so you can follow along and make your own notes. And don't forget to subscribe to the page if you enjoy the content. So let's jump into this one. Kind of looks crazy, but we can distill it down to something a little bit more simple. So the first thing we're going to do is look at the force and get an idea of what we think is going on. And so I look maybe down here at this V5 rhythm strip, and what I see is I have a normal, narrow, complex rhythm that has in between it these early wide complex beats, right? So we alternate from normal, narrow, complex to wide complex, right? And those wide complexes seem to come early, and I say that because, if I drew in between these two QRSs, if I drew a line, right, I would expect that my next beat would be coming kind of on the midpoint of that line. But notice that it comes early, right? So we have early beats, every other beat, okay? And if I look, right, we're still just trying to work through what's going on. In front of my narrow complex beats, we've got these P waves in front of my narrow complex beats. So it makes me think that maybe we've got like some type of sinus rhythm with maybe some premature contractions, right? We gotta kind of work through it. And so what we can do is we can take a look, and so we've got P waves that are upright in lead 1, and they are in AVF, upright in AVF. So that tells me that these P waves are coming from the sinus node, right? So that's kind of our atrial activity. We've got sinus P waves, and I'm trying to figure out maybe what is the rate here. Let's try to figure out what the rate is. Well, what you could do is you could do what's the rate between each of the narrow QRSs. You could determine the rate there, and you can multiply that by 2 because there's an extra beat in between each of them. We might just do that. So we've got 300, 150, 100, 75, 60. This would be 50, so maybe 55 beats per minute times 2. So we've got an average rate of like maybe 110 beats per minute. You could also, if you wanted to, just to get a general rate, you could count the total number of QRSs that you can see in this strip and multiply it by 6 because this is a 10-second strip. So you can do that too. So we've got a fast rhythm here. So I already evaluated my atrial activity. Let's take a look now at what the AV node's doing. And what I mean by that is how often is it conducting those P waves to the QRS, and in what fashion is it doing it. So I can look at my normal PR interval here, and you can see that the PR interval is about 160 milliseconds, right? Which is in between what we would call normal, which is 120 to 200 milliseconds. And you can see that every time we see those P waves before the narrow complex beats, they seem to be normal. And so then I'm trying to figure out, well, I wonder if my AV node is conducting to these wide complex beats. And so I start to look, and I look really closely for a P wave in front of these wide complex beats. And maybe I'll look, I think AVF actually has pretty good kind of example of what's going on here. So you see here's our normal P wave that conducts to this QRS. And then we've got this wide complex beat, right? And here's our T wave for the wide complex beat. If you look in front of the wide complex beat, you could see the start of that P wave right there, right? That looks like a sinus P wave, right? If we have a P wave going from there to there to there, right? That's our sinus P wave that's marching through this rhythm, right? But that P wave, look how close it is to that QRS. That PR interval is way shorter than the PR interval we already said. So I don't think that P wave is causing that wide complex QRS. Right? What could be causing that wide complex QRS? Well, it could be, what I believe is going on is, so we have a sinus P wave that we noted that's coming down the atria, right? And we're getting that P wave. But right as that P wave terminates and gets to the AV node, at the same time we are getting some type of premature ventricular contraction. A premature ventricular contraction coming from the ventricles, firing off, creating slow cell-to-cell depolarization through the ventricles. And that comes And essentially that P wave that is trying to come down through the AV node can't, because the ventricles have already depolarized and they are refractory. And so we're getting that in this very consistent pattern. And so you could say that these are premature ventricular contractions, right? And we know that PVCs that happen every other beat, we can call that ventricular bigeminy, right? So we've got ventricular bigeminy that's landing right after these P waves, right? We got this P wave, and then the QRS is coming in before the AV node can conduct that signal down. And so it's essentially canceling out that P wave. It's not letting the P wave conduct down. So that's what we're having. That's what these red arrow beats are. Pretty neat, right? So that explains a little bit of our AV node behavior, why those next P waves aren't causing narrow complex beats, right? Okay, so let's evaluate our QRS complex, right? Our QRS complex. Let's evaluate the narrow ones, right? The wide complex beats we know are kind of these aberrantly conducted premature ventricular contractions, but the narrow complex beats are upright in lead 1. In an AVF, you can see it's isoelectric, a little bit more negative than positive, right? It's more isoelectric in lead 2, so it's perpendicular to lead 2, right? So lead 2 is here. So our QRS axis is perpendicular to lead 2, and it's what? Negative in AVF, so it's going to be going away from AVF, so it's going to be this way. So we've got an axis of maybe negative 30 degrees, right? Negative 30 degree axis. So we have some type of leftward axis shift, not complete left axis deviation yet. Anything more than negative 30 would be left axis deviation, right? Okay. And let's take a look and see how our R wave progression is. What I see is that in V1 and V2, I have some late signals, right? Look at this RS R prime. See, we've got a little RS R prime. We got a little R prime here in V1. That tells me that we have some late forces actually going towards the right ventricle. So we actually might also have an incomplete right bundle branch block, right? Because we have a narrow complex QRS, right? Our QRS here, our QRS is less than 120 milliseconds. And we have this R prime signal, kind of a right bundle branch block morphology, but it's still a narrow complex rhythm, so we can't call it a full right bundle branch block, right? And so because our axis isn't, completely left axis shifted, then, or deviated, then we don't have like fascicular blocks either. Like we don't have like a left anterior fascicular block. Close, we're really close, but we don't, right? If you don't understand what I mean by that, head over to the ECG curriculum playlist on my page, and I've got some lectures on fascicular blocks. They're blocks off of the left bundle. And so the next thing we're going to do is evaluate our QT interval. Our QT is our repolarization, and so, it's hard to tell, but this is a T wave from our negative or our narrow complex QRS, and luckily these PVCs, you kind of look, are the PVCs close to landing on top of that T wave? And they're not, so I'm not really concerned about this QT interval. I think it's appropriate. So then we look for pathological Q waves, and as T and T wave changes, tells us about previous myocardial infarctions or any current myocardial infarctions, and luckily we don't see any. And so what do we call this rhythm? Well, we've got a sinus rhythm. Actually, we've got a sinus tachycardia at a rate of roughly 110 beats per minute. We have an incomplete right bundle branch block. We have a left axis shift at negative 30 degrees. And we have premature ventricular contractions that are occurring in a pattern of ventricular bigeminy. So, I hope this video helps. If you have any questions about it, please feel free to ask down in the chat below. And yeah, we appreciate all your support of the channel, and we'll see you on the next ECG video. Have a great day.